Hi, I'm Srinivas Murthy. I'm over in Vancouver. I apologize for not being able to come to Toronto for Critical Care Canada Forum, but as you can tell from the topic of my presentation, I think everybody understands the reason for me not flying there. Critical care and climate change. Let's talk. So no known financial disclosures, but likely. I do have some investments. I have a pension plan. I have all of that. And while I have tried hard to divest as much as possible from oil and gas, it is almost impossible to do it completely. So likely. I also personally have two small children, and as many people in the audience, I worry deeply about this issue. I do, however, remain hopeful, largely because of the people that I'm speaking to right now, and the community that is developing around this exact question. And also, there will be politics discussed in this. This is inherently a political issue, and we need to embrace that conversation and have that openly. So I'm here in Vancouver on the unceded territories of the Musqueam, Tsleil-Waututh, and Squamish First Nations. Let's move forward. Is my ICU ready, and can my ICU help? We're going to frame the next 20 minutes in talking about those two ideas. First, let's talk about, can my ICU help? Like all good clinical presentations, let's start with a case. You've got a young patient rapidly deteriorating over recent years, practices self-injurious behaviors, has multiple morbidities, and is now admitted to the hospital. After being unable to accomplish their activities of daily living at home, has every subspecialty is consulted, everybody's arguing against each other, there's no clear management plan, and the ICU is called after a code is called on the ward, a metaphor for where we are currently for climate change. So a code red for humanity, as the Secretary General for the UN has said. So when to begin resuscitation? When are we at a place where we need to throw out all the stops and do everything possible to save and resuscitate a deteriorating patient? Here's our temperature anomalies, the global land ocean temperature index over the past 50 years. You see that chart. Here's ocean heat content over the past 40 years, rapidly rising. Here's where we are with a couple of years ago anyway, with carbon dioxide concentration in the atmosphere, and here's where we have been for the past 800,000 years. That arrow in the top right is not an outlier, it is where we are. It is real data. Also, personally, this is a picture of Carter Vai. His parents allowed us to use his face in this presentation. He's a 9-year-old who suffered from asthma during the wildfires in British Columbia this past year. He had a severe asthma attack, has never had one of those previously. The air quality index on that day was well above normal with smoke in his community in central British Columbia. He had a cardiac arrest in the emergency room. He called our ICU. We were unable to resuscitate him, and he died. He is, his cause of death, effectively, is our worsening climate. How to resuscitate? So ICU, this is kind of what we do. We do crisis resource management. We all know these textbooks. We know how to communicate. We know how to engage lots of people in an emergency. This is our skill set. We have situational awareness. We do generate leadership skills, task management, communication strategies, all these things that we do in a resuscitation, and we have trained for decades to do and to do well. Those skills specifically are what is required right now. So, can my ICU help? This is sort of a rough picture, a pictorial of US data, but similar in Canada, where emissions in US healthcare come from. There's electricity in the top right, some plastics, medical devices, food, waste and water, pharmaceuticals, all sorts of different sources of emissions in US healthcare. Remember, healthcare is about 10% or 5 to 10% of all emissions. US data, probably similar in Canada. So we have lots of ability and lots of control to change a sizable chunk of what's happening right now. We calculate it out. It's about 9 kilograms of carbon dioxide per bed per day for an ICU patient. It's not really including all of the nurse travel, clinician travel, other supplies related to that individual care of that patient, but roughly 9 to 10 kilograms of carbon dioxide per bed day. So it's a useful number to consider as you think about your patients you take care of. And so I think fundamentally, clean electricity. If we want to do anything within our ICU that moves the needle on healthcare emissions, it's largely the ability to use clean electricity within our facilities that's going to make the biggest bang for our buck as it relates to improving our carbon footprint of our institutions and of the care we provide. In Canada, we're not doing great. About 20% of our electricity generation is still under fossil fuels, whether natural gas or coal, with a whole host of other sources of hydro and nuclear and wind, which are more sustainable and or renewable. And so in terms of advocacy, in terms of things to do, natural gas and coal should no longer be powering our hospitals. And so have a conversation with your facilities management folks to see exactly how you can make those shifts happen. Drugs. We talk a lot about drugs in the climate and healthcare movement. There's only a handful of examples that really are useful. Lots of other examples are not that different. And so I'm trying to focus energy on those high yield spaces, specifically thinking about those environmental impacts of which drugs are more relevant than others. We love to talk about anesthetic gases, specifically the halothane, specifically desflurane, which in the UK, for example, is being completely decommissioned, and lots of institutions across Canada are also slowly working their way there. We have no clinical differences across the different inhaled anesthetics, and so moving away from desflurane, which is a substantial greenhouse gas, would be a great move forward. In the ICU, we can continue to advocate for that. Propofol use. Propofol isn't that bad in terms of making it, but its disposal is oftentimes, it's a fairly sizable toxin. And so making sure your ICU has appropriate disposal strategies for propofol, so you're not just shooting it down the sink. Inhalers, we use a lot of inhalers in ICU, and as we discharge patients to the wards, whether it's metered dose inhalers or dry powder inhalers, there is substantial improvements with dry powder inhalers as it relates to metered dose inhalers. You see the carbon dioxide equivalents annually, probably a couple of hundred. And so lots of movements towards getting dry powder inhalers across the board for suitable patients. Plastic waste. I think everyone likes to jump up and down about how much plastic we use in the ICU. We use a lot of plastic, about 2 kilograms of plastic waste per hospitalized patient per day. And so that's about, if you calculate it out and extrapolate to 20-bed ICU, it's about 500,000 kilometers in a gas car in terms of actual carbon dioxide emissions. And so lots of room for improvement there. And so this is largely a hospital problem, not necessarily an ICU problem. You have limited ability to change that outside of advocating to your hospital suppliers about single-use products, their need and their role within clinical care. There are lots of greener type products emerging for clinical care, and it just needs to be advocated for by whoever is purchasing products across your institution, so that those are the ones that arrive in your ICU. We use a lot of plastic, and we do not need to use as much as we do. Travel costs, and so there's all sorts of other things: clinical care, administrative, paper use, commuting, building, as I talked about, and it's travel costs and coming to this meeting. I think flying in an airplane is probably our individual largest source of carbon dioxide emissions as academics and folks who like to travel. And so really reconsidering when and where those travel opportunities happen. And then most importantly, and I think I can't emphasize this enough, is finding like-minded individuals. Great series of articles in ICM over this past year about making your ICU more green, and then highlighting creating your green team in your ICU. So every ICU, like they have a quality improvement team, like they have a Code Blue committee, needs to have a green team or a climate initiative or some other name. And whether it's a formal committee that reports through hospital reporting structures, or whether it's an informal committee, it doesn't make a difference really in terms of how impactful it is. What it needs to be is multidisciplinary across different skill sets and being able to implement things across local practice. And every hospital has different low-hanging fruit that they can implement easily so that they can get the momentum going, whether it's like drug use and metered dose inhalers, or whether it's simple plastic use or plastic bag use or energy advocacy or any of the other things. Just creating that initiative, creating that culture that this is part of your usual practice is so fundamental. This is a great sort of slide that talks about what you can do. I think in critical care and medicine more broadly, we tend to think, okay, the climate folks are working on this, we're going to work on healthcare. But really, like, everybody needs to be involved in climate action. And this is the classic Venn diagram of what brings you joy in life, in healthcare, in your job, what work needs doing on the bottom right, like in terms of what climate and justice solutions are out there. And then finally, what are you good at? What skills do you have? What communities, what networks, what resources do you have available? And in that sweet spot, there's a climate action. And everything has that, whether it's in your ICU, whether it's doing clinical trials, whether it's quality improvement, whether it's in your neighborhood or at your school or anything like that. There is climate action in the space that you love being in, and you can continue to push that agenda. We all need to be doing that. And finally, I think advocacy. I can't emphasize enough the importance of advocacy here. You, as ICU clinicians, are leaders in your hospital and leaders in your community. People listen to you. People care what your thoughts are, and especially as it relates to this issue, your advocacy towards government officials, towards policymakers, towards hospital administrators cannot be understated. You need to tell people what's important, how we can sort of move the agenda on this fundamental topic. Obviously, policymakers are thinking about this. There's all sorts of COP, which is the global conference of countries about climate change specifically, working towards low carbon resilient health systems. Canada is sort of slow off the mark on this. There is an initiative that's Cascades, which is in the top right there, which gives a toolkit for hospitals and other care centers to consider climate action in how to provide healthcare. And so I direct folks there, Cascades, to think about how they can implement those things at their hospital. And finally, also advocacy, advocacy, advocacy. So is my ICU ready? Next, let's talk briefly about that, because things are going to change. Fundamentally, I think the idea that Choosing Wisely Canada, which many folks know, is in terms of providing recommendations to provide high value care to the right patients, and about less being more. And so while we think about things that we can do that are climate specific, we have to think about the things that we do that are unnecessary and are costly and come with like patient level costs, climate level costs, and economic costs. And by doing less, which we know to be more across a number of different clinical questions, we are providing huge benefit to the climate, transfusing less blood, for example, waking patients up, extubating them early, providing ICU care to the right patient at the right time. All of these things are high value for cost, high value for patients, and high value for the environment. So back to, is my ICU ready? Lots of things could change. There's new diseases, there's new weather patterns, there's new respiratory illnesses, wildfires, and all of these things. And thinking about whether your ICU has sort of protocols in place for all of these things to occur. We know that hospitals themselves are susceptible to disasters. And if you look at hospitals in the United States, about a quarter of them are at high risk of flooding because of changing weather patterns. If you look at Hurricane Sandy, for example, there was a huge problem with evacuation during that disaster. And so thinking about how your hospital and ICU can update its disaster readiness plan so that for that eventual emergency that occurs, whether it's flooding or hurricanes or what have you, you are ready. We had out in BC a couple of years ago, a huge heat dome, which caused a many hundred numbers of deaths, and we were not prepared in healthcare, and we were not prepared across our hospitals. And so thinking about policies and protocols to both prevent heat diseases and manage them accordingly with appropriate treatment protocols and available resources. All of these things are going to happen and going to happen more in the future. Infectious diseases, much more frequent after a changing climate, either following disasters where you get a different endemic disease pattern, or new infectious diseases. Dengue is spreading all over the world right now in Southern Europe and Southern United States, for example, in places where it wasn't before, largely related to a warming and changing climate. COVID-19, obviously a new infectious disease, not directly climate related, but we all saw the impact of how new diseases can cause problems in the ICU world. Particulate matter and wildfire smoke and how it impacts respiratory and cardiovascular health. You see as wildfire exposure increases, respiratory health worsens. And I think that is fairly self-evident, and just getting the systems in place to respond to that accordingly. Also, not just disease incidence, but disease transmission also. More particulate matter leads to more COVID transmissions because of that particulate matter that's present in the air, leading to vectors for airborne transmission of a disease. Also, of course, seasonal air pollutants found to be associated with higher mortality, not just increased incidence of disease, respiratory disease, but higher mortality for folks who have that disease also. And fundamentally, I always have to sort of end these talks with thinking about where the problem is worst, and making sure that we focus our attention and our resources to the people who will be most impacted by those things. And in this context, it's the Global South, where the exposure to air pollution will be greatest, where the heat emergencies will be greatest, and the infectious disease impacts from a changing climate will be greatest. So thinking about how we in Canada and the ICU community can support our colleagues, can support communities around the world as this problem expands rapidly. And so always emphasizing global solidarity. Pakistan and India, for example, every year are experiencing 50-degree temperatures and huge amounts of morbidities attached to that. So lots of things for you to do back in your ICU, lots of things to do outside of your ICU with your community and with your policymakers. I empower all of you to start thinking really hardly about what you can do and where your expertise is best suited. It is, as Antonio Guterres says, a code red for humanity. But in the end, all rebellions are built on hope. And so that little bit of hope is important to maintain so that we can continue to push forward. And thinking about your sphere of influence, whether it's in your ICU, in your university, in your community, in your professional society, at local politics, at national politics, thinking about who and what you can talk to change policy to move the needle on this fundamental topic. As we all know, ICU community responded with all of its energy to COVID-19, but obviously waiting in the wings is climate change. And we need to bring our ICU skills specifically to this fight. We are, in the critical care community, uniquely impacted by, but also can uniquely impact this climate emergency, and it's time to act. This is the sickest patient any of us have ever dealt with. We can, however, still save it. This is a picture of a climate protest, and those are my contact information if you'd like to be, one, more involved, and two, like to share ideas. Thank you.